Hello everybody. Today we are going to discuss the case of raised ICP and how to reverse the anticoagulation agent. So we'll have this case-based discussion on this. So we have this 69-year-old female patient with no comorbidities. She was referred from the outside hospital on 28th of on 28th February 2024. She was presented with the right-sided facial weakness and the right upper limb weakness. MRI brain was taken, which showed the left MCA infarct. She was started on the conservative management, and she received the 5-day treatment there, and she went to home. And at home, she became unresponsive, like the overall response of the patient was reduced, and immediately she was shifted to the hospital. So MRI brain was done, which showed the hemorrhagic transformation, left frontoparietal bleed. She was intubated in ER in view of low GCS and then shifted to ICU. On arrival in the ICU, her pulse rate was 54, blood pressure was 160 by 90, RR was 22, and SpO2 was 100% on PRVC with FiO2 of 40%. So on systemic examination, CVS S1 S2 present, RS air entry equal on the both side, per abdomen soft non-tender, pupils were non-reactive. On the right side it was 3, on the left side it was 2, and the overall GCS of the patient was V1, VT, M5. So issues with this patient was left MCA infarct with the hemorrhagic transformation, which was causing the raised ICP. So because of this, we have transfused her with the 2-point STP and the 2,500 unit of prothrombin complex concentrate. So this was the initial CT of this patient. And this CT we have repeated after 12 hours. So we'll see how what is the raised ICP and how to manage this. So raised intracranial hypertension is defined as sustained elevation in the ICP above 22 mmHg. Typically, normal ICPs are less than 15 mmHg in adults. Although ICP is the pressure within the skull, it directly correlates with the cerebrospinal fluid pressure. Notably, the intracranial pressure measurement demonstrated the pulsatile signal influenced by the cardiac cycle. The signal is represented by the 3 peaks in the waveform. Now these are the ICP waveform. The ICP waveform which was represented in the green shade is the normal ICP waveform, which was characterized by the P1, P2, P3, and this the ICP waveforms which were represented by the pink shade was the caused. These ICP waveforms are caused by the low systolic blood pressure. In this P1 is of the low amplitude, and ICP waveform which was caused because of the high systolic blood pressure is represented in the sky blue shade, which was represented by the peak in the P waveform, which was followed by the fall in the P2 and P3, and the waveform which is represented in the blue shade showed the increased ICP and the low compliance, and the critical ICP waveform is represented, it's shown in the red shade. So the intracranial space is closed system composed of the 3 components: the parenchymal tissue, cerebrospinal fluid, and the blood supply. Given the brain volume is the mostly fixed factor, the cerebral blood flow and the production absorption of the CSF are the main contributor to the ICP fluctuations. When ICP rises, the distal cerebral arterioles vasodilate to the lower cerebral vascular resistance to prevent the ICP and the cerebral blood flow elevation. The arterial blood pressure increases if this initial compensation mechanism cannot sustain the adequate cerebral blood flow. Both of these mechanisms will increase the cerebral blood volume. Consequently, the ICP will rise until the cerebral blood flow is terminated. This manifestation is how secondary CNS insult occur following primary injury. Herniation results from the increased intracranial compartment pressures leading to the parenchymal tissue shift that compresses or displace the cranial nerve or brainstem. Vascular compression can lead to the ischemia or infarction, leading to the edema and further brain tissue compromise. Direct ICP measurement requires the invasive monitoring. Now, the diagnosis, history, and physical examination. A thorough history, physical examination are foremost in the starting the process. Clinical signs of increased ICP include headache, nausea, vomiting, changes in the mental status, for example, confusion, decreased mental ability, coma, and loss of consciousness. In the ED, there are two scores which help in assessing the patient consciousness quickly. These are the glaucoma scale and the full outline of unresponsiveness, that is a 4 score. The 4 score was developed as an alternative to the GCS when evaluating patients with the impaired consciousness and the possible neurological injury, especially in intubated patients who cannot be assessed fully. Exam finding can also vary when herniation and structural shift occurs. Physical manifestation of the ankle herniation can include ipsilateral pupillary dilatation, contralateral hemiparesis, or acute loss of consciousness. Also, the midbrain herniation can result into the ipsilateral hemiparesis. The late manifestation of increased ICP is Cushing's triad, which include hypertension, bradycardia, irregular respiration, or apnea. A baseline physical examination is important to later assess for the subtle neurological changes that may require escalation in therapy. So this is the glaucoma scale, which includes eye opening, best verbal response, and the motor response. So 4 score is for the spontaneous eye opening. If eye opening to the speech, then 3. If to the pain, then 2. If no response, then 1. And verbal responses scored as follow, like if patient is oriented to the time, place, person, then 5. If confused, 4. Inappropriate words, 3. Incomprehensible sounds, 2. No response, 1. Then the best motor response, if the patient obeys command, 6, moves to the localized pain, 5, flexion withdrawal from the pain, 4, abnormal flexion, 3, abnormal extension, 2, no response, 1. Then the full outline of the unresponsive score, if it includes eye responsiveness, that is 4 score given to the eyelid open, trackling and blinking to command. 3. Eyelid open but not tracking. 2. Eyelid closed but open to loud sound. 1. Eyelid closed but open to pain. 0. Eyelid remain closed with pain. Then motor response, 4 score has been given for the thumbs up, fist, and the peace sign. Then 3 localized to the pain, 2 flexion response to pain, 1 extension response to pain. Then the brainstem reflexes, 0 no response to 3 4 pupillary or corneal reflex present. 3. 1 pupil wide or fixed. 2. Pupillary or corneal reflex absent. 1. Pupillary or corneal reflex absent. 0. Absent pupillary, corneal or cuff reflex. Then respiration, 4. 4 score if not intubated, regular breathing pattern. 3. Not intubated, kind stop breathing pattern. 2. Not intubated, irregular breathing pattern. 1. Intubated, breathe above ventilator rate. And 0. Intubated, breathe at ventilator rate or apnea. Then invasive monitoring. Invasive monitoring with the extraventricular drain or an intraparenchymal monitor remains the gold standard for the ICP monitoring. In patients with the traumatic brain injury, guidelines suggest placing an ICP monitor in those who are comatose after adequate neurological resuscitation and show either abnormalities in the computed tomography of the head and meet following of the 3 criteria, that is age more than 40 years, systolic blood pressure less than 90, and abnormal posture. Cerebral perfusion pressure can be used as surrogate marker for the cerebral blood flow, which is and this cerebral perfusion pressure is MAP minus ICP. Data supports maintaining cerebral perfusion pressure of around 60 to 70 mmHg to prevent cerebral ischemia. There is little evidence on the insertion of timing of invasive monitoring. Hoffman and colleague performed the retrospective cohort study and concluded marginal mortality reduction in early invasive monitoring placement versus late. They concluded that the early detection of elevated ICP assisted by invasive monitoring could result into the prompt treatment. Now the next is quantitative pupillometry. Non-invasive monitoring techniques have been introduced in the detection of elevated IC. Examining the pupillary light reflex that has always been an integral part of the comprehensive neurological exam. Traditionally performed with the pen light, the pupillary light reflex has been replaced with the automated pupillometer assessment. Examination of the pupillary reflex utilizes the pen light, developed descriptive terms such as sluggish, brisk, non-reactive, or fixed. Not to mention, it was difficult to assess the circumstances in which exam took place. In an effort to minimize subjective language and develop unified standard definition, automated pupillometer was introduced. This tool provides objective measure of pupillary constriction, dilatation, velocities, pupil size, and latency. The tool uses an algorithm to calculate index called as a neurological pupil index, which measures the pupil's reactivity. The numerical range is from 0 to 5, where value greater than or equal to 3 indicates normal activity. Abnormal neurological pupil index less than 3 can be associated with damage to third cranial nerve or possible damage to the brain. Several studies have linked the association between poor neurological pupillary index and elevated ICP. McNett et al. Suggested that increased ICP may be revealed as a decreased neurological pupillary index and reduced contraction velocity with minimal change in the pupillary size. Many other studies detected an inverse relationship between ICP and neurological pupillary index values. Samir et al. Concluded that patients with the lower pupillary light response, lower NPI, reduced constriction velocity, and slower dilatation velocity had increased ICP value that is more than 15 mmHg. The use of pupillometer to obtain quantitative data of pupillary light response using NPI is useful in the early detection of elevated ICP. Now, the next is the point of care ultrasound. Point of care ultrasound has been studied for use in detecting elevated ICP via measurement of optic nerve sheath diameter. As ultrasound is readily available in most emergency department, assessing this optic nerve sheath diameter can quickly offer additional information for appropriate management. The optic nerve sheath diameter, it is an indirect measurement of raised ICP and can be measured via brain CT and ocular ultrasound. The subarachnoid space of the optic nerve sheath and the brain are anatomically connected, thus allowing CSF to circulate from the perichiasmatic system to the ocular areas. As ICP increases, the pressure drives the large quantity of CSF towards the orbital space, resulting into the enlargement of optic nerve sheath diameter. Literature also compresses the optic nerve sheath diameter to eyeball transverse diameter by ultrasound to predict elevated ICP. Now, the next tool is the computed tomography of the head. The Fernando and colleague evaluated multiple CT signs of elevated IC, including basal cistern compression, midline shift of varying degree, more than 5 or more than 10 and Marshall classification system. The Marshall classification system of the traumatic brain injury, which includes this classification. Class 1, that is diffuse injury 1, that is no visible pathology seen on the CT head. Then diffuse injury 2, it showed the midline shift of 0 to 5 basal cistern remains visible, and no high or mixed density lesion of more than 25. Then diffuse injury 3, that is a class 3, indicates the midline shift of 0 to 5 basal cistern compressed or completely effaced, no high and the mixed density lesions of more than 25. Then diffuse injury class 4 includes the midline shift of more than 5 no high and the mixed density lesion of more than 25. Then class 5 include evacuated mass lesion, that is any lesion evacuated surgically. And class 6 includes non-evacuated mass lesion, that is high or mixed density lesion of more than 25 and not surgically evacuated. Then sensitivity and specificity of diagnosis of elevated ICP. If there is an absence or compression of vessel system, then it has a sensitivity of 85, specificity of 61. Any midline shift carries the sensitivity of 80%, specificity of 42. Then severe midline shift of more than 10 carries the sensitivity of 20%, specificity of 89. Now, the newer city scoring system have been discussed since the Marshall system, such as Rotterdam score, Stockholm score, and the Helsinki city score. A recent study have compared many of these score in the outcome predictor of mortality instead of diagnostic utility. More research is required to accurately depict whether this scoring system provide any diagnostic information that directly correlates with elevated ICP. Other devices that can aid the diagnosis of elevated ICP include EEG and transcranial Doppler. Now, this is the overall view of the management of raised ICP, which is like tier 0. That is, it includes all standard measures, like we should assess the proper airway breathing circulation. Then we should minimize the noxious stimulus. Then we should give the proper analgesic and sedations to the patient. And we should target for the normal body temperature, neutralize the head of the patient that then give the proper position to the patient of more than 30. Then we should give the iso or hyperosmotic fluids. Then avoid or correct the hyponatremia. Then give the steroids in select conditions. Obtain non-contrast head CT. And tier 1 measures include you should start the hyperosmolar therapy, temporary hyperventilation to maintain the PCO2 between the range of 30 to 35, CSF drainage, and we can consider surgical decompression. And tier 2 measures include hyperosmolar therapy for high sodium goals, optimized sedation and analgesia, rescue decompression surgery should be considered as a life-saving intervention. And tier 3 measures include sedation titrated to the ICP goal or burst suppression on EEG, hyperventilation to achieve the mild moderate hypocapnia, and moderate hypothermia. Then management of increased ICP should be tackled systematically in the emergency department. The emergency neurological life support created the simplified, tired approach for the management. Initiating sedation and analgesia helps reduce noxious stimulus that may increase ICP. In addition, elevating the head of the bed more than 30 degrees, keeping the neck midline assists the cerebral venous drainage. Then next is the hyperosmolar therapy. Hyperosmolar therapy, including mannitol and the hypertonic saline, has equally shown benefit in lowering ICP. Mannitol is given as 0.5 to 1 gram per kg IV bolus via the peripheral intravenous line over 5 to 15 minutes, and this can be repeated every 4 to 6 hours. Then we have to monitor adequate dosing based on the osmolar gap. Osmolar gap more than 20 mmosmol per kg has shown no benefit. Then the next is the hypertonic saline is available from the 2% to 23.4% and can be administered as a bolus alone or with the mannitol. The concentration of the hypertonic saline greater than 7.5% should be given through the central venous catheter. Concentration less than 7.5% can be bolus via the peripheral line. However, infusion should be given in the large vessels. Then the various sodium concentration, osmolarity, and bolus dosing for hyperosmolar agent. Mannitol, mannitol 20%, like mannitol 25%, and the hypertonic saline is available in the concentration of 3%, 7.5%, and 23.4%. But the continuous infusion and the rate depends upon the targeted sodium as well as no specific rate is recommended. However, to reach desired serum sodium concentration goal, one can implement the Andrew-Medeiros formula, that is a change in the serum sodium is equal to infused sodium minus serum sodium upon total body water plus 1. So with hypertonic saline, the serum sodium concentration should be monitored every 4 to 6 hours, and this concentration should be kept below 160. Now the next is anti-epileptic measures. Seizure activity can be seen in those with the increasing ICP. So the seizure activity can increase the cerebral metabolic demand and worsen the ICP. So anticonvulsant should be considered in those with the increased ICP, especially depending upon the etiology. Patient with the traumatic brain injury, intracranial hemorrhage, subarachnoid hemorrhage, large volume ischemic injury would benefit from the prophylactic anticonvulsant therapy. So phenytoin and levetiracetam, these are the two most commonly used agents. Prophylaxis has been shown to prevent early seizure activity but not post-traumatic epilepsy. So there is no evidence to suggest loading dose therapy is beneficial in preventing seizure or progression to epilepsy. So next major is the induction agent and sedation. So the fentanyl has been used in the pre-medication to blunt increase in ICP related to the laryngotracheal stimulation and rapid sequence intubation. In normotensive or hypertensive patient, an intravenous bolus of fentanyl, that is 2 to 3 mg per kg, 3 minutes prior to induction is recommended. Fentanyl is a hemodynamically neutral drug. However, it can decrease mean arterial pressure and cerebral perfusion pressure when given in the bolus dose. So etomidate is commonly used as an induction agent in patients with the traumatic brain injury because it can decrease the cerebral blood flow, cerebral metabolic demand while preserving cerebral perfusion pressure. If ICP remains a concern, increasing sedation can assist in the management. Propofol can decrease the cerebral metabolic demand and cerebral blood volume. So the bolus dose of 1 to 2 mg per kg can be administered, followed by the continuous infusion to maximum of 200 microgram per kg per minute in ventilated patients. However, propofol has increased propensity to cause systemic hypotension. A MAP of 80 to 110 mmHg should be targeted to maintain CPP greater than 60 mmHg. A vasopressor can be implemented to maintain cerebral perfusion pressure. A tier 3 focuses on most aggressive level of the management, and this tier titrates the sedation to ICP goal or burst suppression on continuous age. Pentobarbital can be administered and titrated to both goal bolus of 5 to 15 mg per kg over 30 minutes to 2 hours, followed by maintenance infusion of 1 to 4 mg per kg per. Midazolam has the neutral hemodynamic profile and can lower the systemic blood pressure, thus reducing CP. Another concern surrounding midazolam is its ability to accumulate into the adipose tissue over time, resulting in delayed awakening. So, midazolam has also been shown to increase ventilatory rates, prolong coma, and ICU length of stay. However, its anticonvulsant and anxiolytic properties can be beneficial in certain cases. The use of ketamine has been controversial in patients with the head injury. It was thought that its protective effect on sympathetic stimulation might cause a rise in ICP via stimulation and exacerbate the underlying condition. However, when ketamine is used along with the aminobutyric acid receptor agonist, the ICP may not rise in ICP may not occur. Ketamine may also be considered beneficial by increasing cerebral perfusion through transient increase in systemic blood pressure. Kumar and colleague literature reviews the determine that ketamine can be used safely in patients with a traumatic brain injury, although no large clinical trial has been done. Ketamine also positively affects the intracranial pressure in dose-dependent fashion. Usually, dose less than 4 mg per kg decreases the intraocular pressure. However, due to limitations and weakness, several retrospective prospective studies have not been able to conclude solid recommendation on ketamine use in this population. So the next is paralysis. There is not enough current evidences to recommend rocuronium over succinylcholine for rapid sequence intubation in patients with the traumatic brain injury. Notably, it was shown that sustained paralysis with the rocuronium could prevent the repeat neurological examination. Patients who receive rocuronium are also administered less sedation and analgesia post-intubation because paralysis makes it appear the patient sedated. In addition, rapid offset of succinylcholine allows for early neurological exam. Now, this table showed the various physiological effect of various sedative agents. Now, the next is ventilation. While additional therapies are being implemented, a brief moment of hyperventilation, that is less than 2 hours, with PaCO2 target of 30 to 35 mmHg. In addition, hyperventilation for a goal of mild to moderate hypocapnia with the PCO2 target of 25 to 34 mmHg may be considered in patients who have failed the other management strategies. However, hyperventilation for more than 6 hours is unlikely beneficial and may exacerbate ischemic injury due to cerebral vasoconstriction. Ideally, cerebral oxygen monitoring tools such as jugular venous oximetry and brain tissue oxygen monitoring should be implemented to monitor for cerebral ischemia. Now, the next is surgical intervention. Notably, the early surgical decompression is recommended by ENLS if tier 1 is ineffective in reducing ICP. However, if surgery is inappropriate, tier 2 should be the next step in the management. Rescue decompression surgery is the last step in the tier 2 as life saving intervention because tier 3 therapy implies the patient is no longer candidate for surgery. A decompressive craniotomy aims to remove the portion of skull, allowing brain room for expansion to decrease ICP and improve blood flow and cerebral oxygenation. Large craniotomies are preferred over small size to decrease mortality and improve neurological outcomes. So the Cochrane Library reviewed 3 trials with the 590 participants and concluded that decompressive craniotomy decreases mortality. However, long-term neurological outcomes are controversial. Given that most neurological injuries focuses on long-term functional outcome, family discussion on care, goal, quality of life would be warranted. Future studies should focus on most appropriate timing for decompressive craniotomy, ideal technique, and patient long-term functional outcome. So these are the two trials, which is the DECRA trial, and we published in 2011 in New England Journal of Medicine, which conclude with it adult with the severe diffuse traumatic brain injury and refractory intracranial hypertension, early bifrontal temporal parietal decompressive craniotomy decreases intracranial pressure and length of stay in ICU, but was associated with the more unfavorable outcome. Then in 2016, there is a rescue trial was published in new NEJM, which concluded that decompressive craniotomy in patient with the traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rate of vegetative state, lower severe disability and upper severe disability than the medical care. Now we'll deal with the next issue of that patient, which was bleeding, which happened because of the anticoagulation. So we'll see how to reverse this anticoagulation. So this intracranial hemorrhage is the disease entity associated with the higher morbidity and mortality. It accounts for nearly 15% of all strokes. In USA, the mortality rate of the patient with the ICH is nearly 34%, confirming the increased burden of the disease. So the oral anticoagulation is the common cause of ICH, and the use of oral anticoagulation is estimated to continually rise given the increasing rate of atrial fibrillation detection. Coagulopathy associated with the ICH results in the poor functional outcome and given the rapid hematoma expansion as early as 1 hour. So this discussion will review the medical indications, efficacy, safety of vitamin K as well as direct oral anticoagulation and outline the reversal of coagulopathy by these agents. So the comparison of efficacy and safety between the direct oral anticoagulants and vitamin K antagonists. Direct thrombin inhibitors and factor V inhibitors constitute the two classes of direct oral anticoagulants. So the dabigatran is the direct thrombin inhibitor, while rivaroxaban, apixaban, edoxaban, and the betrixaban fall in the category of the factor Xa inhibitor. Direct oral anticoagulant do not require frequent monitoring of the INR and have shortened half-life with the fewer drug interaction, making them more favorable for use than the warfarin. So recent trial, including Aristotle trial, which include apixaban, Raleigh trial, Rocket AF trial, then Engage AF TIMI trial on stroke and systemic embolism have shown non-inferiority of the direct oral anticoagulant when compared with the warfarin. The rate of bleeding is also lower for a direct oral anticoagulant at 3 to 4% when compared with the warfarin at 5 to 6%. So the rate of ischemic stroke in patients taking direct oral anticoagulant has been noted to be higher when compared to warfarin. This could be explained by inconsistent use of direct oral anticoagulant resulting in subtherapeutic level given their short half-life. The outcome of ICH while on direct oral anticoagulant remains a topic for research. The CHROMIS 2 compared all-cause 90-day mortality, functional outcome, ICH volume, and hematoma expansion between the patient with the ICH associated with the vitamin K antagonist and ICH associated with the direct oral anticoagulant. So there were no significant differences between these two. Other studies have shown similar functional outcome in patients with the ICH receiving vitamin K antagonist and direct oral anticoagulant, and also the mortality benefit in patients with the direct oral anticoagulant. So these direct oral anticoagulants are becoming the preferred agent for all oral anticoagulation when compared with vitamin K given their safety profile. There is limited data on reversal protocol of direct oral anticoagulant as their use will continue to rise, and it is imperative to understand the management of direct oral anticoagulant related ICH. This reversal of vitamin K antagonist related coagulopathy. Warfarin interferes with the production of vitamin K dependent clotting factor, that is 2, 7, 9, 10, by depleting vitamin K reserve. So the warfarin is metabolized by the cytochrome P450 enzyme, which can be inhibited and induced by the variety of drug, resulting in variable metabolism of warfarin. So the direct acting oral anticoagulant and reversal. So dabigatran, the mechanism of action is direct thrombin inhibitor, and the reversal agent is idarosuzumab, rivaroxaban, that is commonly known as Xarelto. It is also the factor 10A inhibitor, and the reversal agent that we can use is the factor 3 and factor 4 prothrombin complex concentrate and the adzanate alpha. Then edoxaban, the reversal agent is again andexanet alpha. So vitamin K is available in the oral, subcutaneous, and the intravenous preparation for patients with the life-threatening bleeding. So this intravenous vitamin K is the most efficacious among the three, with the recommended dose of 10 mg IV. However, INR normalization with vitamin K can take up to day one or day 1 or 3, and therefore it is not sufficient alone in the management of ICH. So it is usually given in the combination with fresh frozen plasma or prothrombin complex concentrate. FFP is the liquid portion derived from the whole blood. It corrects coagulopathy by replacing plasma protein to replete clotting factor. FFP reversal of INR can take up to 30 hours, making it ineffective treatment of early hematoma expansion. It requires higher volume and worsen the fluid balance in patients with heart failure, resulting in pulmonary edema as well as transfusion reaction. PCC comprise of clotting factor 2, 9, and 10 at levels significantly higher than the FFP. This activated PCC also contain the factor 7 in addition to factor 2, 9, and 10. PCC results in the rapid INR reversal and is not associated with the complications such as fluid overload as seen in the FFP. The INCH trial, that is international normalized ratio or normalization in the comedine associated intracerebral hemorrhage compared 30 unit per kg dose of PCC to 20 ml per kg of FFP in reversal of vitamin K associated ICH. So this PCC have a higher rate of INR reversal to 24-hour for FFP, and hematoma expansion was less for PCC group at 3 and 24 hours. The rate of thrombotic complications over FFP as outlined above. A PCC, that is 20 international unit per kg, is found to be more efficacious than FFP without significant increase in thrombotic complication. There are no studies comparing APCC with PCC to date. Now, this reversal of direct oral anticoagulation related coagulopathy and pharmacology of direct oral anticoagulation. Dabigatran directly compete with the thrombin, thus inhibiting the production of the fibrin. It has a half-life of approximately by the kidney. The factor 10A is acted by binding and inhibiting factor 10A with half-life of 6 to 12 hours, except for the betrixaban, which is approximately 24 hours. They are also primarily cleared by the kidney. Unfortunately, like warfarin, dabigatran has no modality which accurately measures its anticoagulation effect. Currently, the specific anti-10A assay are available for factor 10A, but they are not widely available. They have a complex measurement system and they are relatively expensive. In vitro study have demonstrated that PCC efficacy in reversal of direct oral anticoagulation in ex vivo study have been done in small population of healthy male volunteer that proven the efficacy of both 3-factor PCC and 4-factor PCC at 50 unit per kg, and both type PCC decreases the PT within 30 minutes. Multiple multiple trials have been conducted in actively bleeding patients. The UPTRED trial showed that 4-factor PCC reliably reversed 84 patients with major bleeding on apixaban and rivaroxaban, and the overall mortality was 32% at day 30 for both the drugs. There are anticoagulant reversal agents specific for different direct oral anticoagulation. Idarucizumab is the monoclonal antibody that binds the dabigatran. Reverse AD trial enrolled the patient with active bleeding and patient that need reversal of anticoagulation prior to the procedure. Unfortunately, the study was not designed for patients with ICH. Hemostasis in ICH. Therefore, idarucizumab was shown to reverse the effect of dabigatran for approximately 93% of patients within the minutes. Recently, Food and Drug Administration approved the andexanet alpha, the second direct oral anticoagulation specific reversal agent. It is an elegant reversal agent for factor 10A, and it is a recombinant factor 10A that binds the factor 10A1. The Annexa 4 trial had 168 patients with the ICH, and hemostatic. Those with the ICH, 80% achieved excellent and the good hemostasis in 12 hours after infusion. Now, these are the anticoagulant reversal agent and their pharmacokinetics. Idarucizumab, this half-life is 10 hours. Prothrombin complex concentrate, that is K-centra. Time to reverse coagulopathy is 40 minutes. And the elimination is factor dependent. The fresh frozen plasma time to reverse coagulopathy is more than 24 hours. And andexanet alpha, the time to reverse coagulopathy is within the minute. Now, this is the reversal agent with the dose, that is prothrombin complex concentrate, the commonly known as K-centra. If INR is 2 to 4, then we can use in the dose of 25 unit per kg. If INR is more than 6, then we can use in the dose of 50 units per kg. If PCC, then the PCC, the general dosing range is 50 to 100 unit per kg every 6 to 12 hours. And this factor 7A, that is dose recommendation for warfarin related intracerebral bleed, that is 10 to 100 mics per kg. So only Kcentra is FDA approved, not this factor 7A and other one. So these are the summary of the trial, which are for anticoagulant reversal in the hemorrhagic event. The first is INCH trial, which uses the which compare the vitamin K antagonist and the anticoagulant reversal with the PCC and FPP. Results are PCC had a higher rate of INR reversal. Then the UPTRADE trial, which include rivaroxaban, apixaban, and versus four-factor PCC, which showed four-factor PCC reverses the apixaban, rivaroxaban associated bleeding. Reverse AD trial, which showed this idorizumab reverses the effect of dabigatran for most patients within the minute. Then the Annexa 4 trial, the result of this trial was 80% of those with the direct oral anticoagulant associated with the ICH achieves excellent and the good hemostasis within 12 hours after adnexanet alpha. Then the Spotlight and Spot trial, which uses the factor 7A. Factor 7A did not improve the radiographic findings. On recombinant activated coagulation factor 7A, there is a growing interest in the recombinant activated factor 7A in the form of active bleeding associated with the coagulopathy. It was recently compared with the placebo in patient with the ICH and the spot sign on angiography. The study analyzed 69 patients pulled from the Spotlight and Stop It trial. These trials were closely coordinated between the investigator in the Canada and the USA. Patients were given the factor 7A within 3 hours of the stroke onset, and the primary outcome was the parenchymal ICH expansion, and the secondary outcome was the total hemorrhage volume expansion on head CT at 24 hours. The drug did not improve the radiological findings or outcome compared with the placebo. The baseline media ICH volume were 19.6 mm in factor 7A group and 20.4 in the placebo. This further adds to the growing evidence against the factor 7A as a reversal agent. So this is the schematic representation of the anticoagulant use and their reversal. Like reversal of the dabigatran, we can do it with the idorizumab, that is 5 gram IV, and four-factor prothrombin complex concentrate. If idorizumab is not available, four-factor prothrombin concentrate we can use in the dose of 50 units per kg. Then for the reversal of the vitamin K warfarin, we can use this four-factor prothrombin complex concentrate. If, as mentioned in the previous table, if the INR is 2 to 4, then we can use in the dose of 25 units per kg. If INR is 4 to 6, then 35 units per kg. If INR is more than 6, then 50 units per kg. And maximum that we can use is the 5,000. Then we have to check the INR at 1, 6, and 24 hours after giving four-factor prothrombin complex concentrate. If INR is less than 1.5 at 1 hour, then we can give the additional four-factor prothrombin complex concentrate or 2 to 4 unit of the FFP. If INR is more than 1.5 at 6 hours, then vitamin K 10 mg. Then reversal of the factor 10A. 10A, that is rivaroxaban, apixaban, edoxaban, or betrixaban. One dose of activated charcoal. If last dose of rivaroxaban has been taken within the 6 to 8 hours, apixaban less than 6 hours, or endoxaban less than 2 hours. Otherwise, use adnexanet alpha, that is 400 mg IV bolus, and 480 mg IV infusion for last dose, if last dose has been taken for more than 8 hours. Or we can use in the dose of 800 mg IV bolus or 960 mg IV infusion for last dose taken in the if last dose is taken in the less than 8 hours. 4-factor prothrombin complex concentrate in the dose of 15 units per kg if adnexanet alpha is not available. Then for the reversal of heparin, we can use 25 to 50 mg fixed dose of protamine complex concentrate, protamine sulfate. Uh, Reversal of low molecular weight heparin, that is enoxaparin, dalteparin, or tinzaparin. Adnexanet alpha is preferred, and the protamine sulfate if adnexanet alpha is unavailable. And we can use in the dose of 1 mg of the protamine for 1 mg of enoxaparin for last dose. If last dose is taken within less than 8 hours, then 0.5 mg of the protamine if last dose has taken for more than 8 hours, and 1 mg of the protamine. Uh, hmm, Thank you.